Welcome everyone to this month's discussion of an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It gives me great pleasure to welcome Dr. Amol Sharma. Dr. Sharma is an associate professor at the Medical College of Georgia, Augusta University with a clinical and translational research focus in neurogastroenterology and motility. His research focus is understanding the pathophysiology of disorders of brain-gut interaction and developing innovative, non-invasive, and effective neuromodulative therapies. Both his clinical interest and research focus involve patients with diabetic gastroparesis, Parkinson's disease, and fecal incontinence. And his research is predominantly funded by NIDDK with an NIH, Parkinson's Foundation, and the American College of Gastroenterology. Today, he joins us to discuss his recent paper, Randomized Controlled Trial of Home Biofeedback Therapy versus Office Biofeedback Therapy for Fecal Incontinence, which was published in the current issue of Neurogastroenterology and Motility. Welcome, Dr. Sharma, and thank you for joining us for this chat today.
Thank you, Purna. First, on behalf of my co-authors, I'd like to thank you and the editors of Neurogastroenterology Motility Journal for selecting our paper and giving us an opportunity to discuss our work, which highlights the important medical problem of fecal incontinence in further detail.
It's a pleasure. And I'm also, before we get started with the study itself, can you give some background of what was the motivation for the study or why you felt it was needed to do a study like this?
Yeah, sure. Let's start off with what is fecal incontinence? Fecal incontinence is the unintentional leakage of mucus or liquid stool, also called accidental bowel leakage. It's pretty common. It occurs in about 7 to 15% of the US population. It affects both genders, although men are classic underreporters, and its prevalence increases with age. Fecal incontinence from the patient perspective, as you can imagine, is embarrassing and leads to worsening of psychosocial problems such as isolation and anxiety and depression, and it significantly impairs quality of life. Also, fecal incontinence alone is associated with a higher incidence of and worse stage decubitus ulcers compared to urinary incontinence and combined fecal and urinary incontinence. From a caretaker's perspective, fecal incontinence is often the last straw in taking care of an elderly family member with increased stress and caregiver burden. It is the second most common reason for a nursing home referral. So in sum, you can see how bills quickly add up for these patients with fecal incontinence, and these patients have a 55% higher healthcare expenditure. Patients and some providers often believe there's not really any effective treatments for these patients. One of the most successful and least invasive treatments for fecal incontinence is biofeedback therapy. Biofeedback therapy does have varying protocols. However, the most successful protocols involve manometry or EMG-based approaches, where a device or catheter is inserted into the anal rectum, and there's real-time feedback given to both the therapist and the patient of anorectal pressure profiles, and it guides patient maneuvers and adjustments. Biofeedback therapy works with patients to improve anal sphincter strength, endurance, and selective recruitment without contraction of any surrounding muscle groups as to worsen incontinence episodes. Efficacy of biofeedback therapy ranges widely from 44 to 86% in randomized controlled trials, and it is recommended as a treatment for fecal incontinence by both motility societies, American and European. Typically, biofeedback therapy requires anywhere from 4 to 8 office visits. It's labor-intensive, time-consuming for both patients and providers, requires missing work, and it's unclear whether it provides a durable response. Another major limiting factor of biofeedback therapy is there are just not very many well-trained therapists. Biofeedback therapy that would be available to patients in the privacy of their own home would overcome a lot of these limitations. In 2014, the FDA approved a home biofeedback therapy device for both urinary and fecal incontinence. It was proven to be effective in urinary incontinence. However, its clinical efficacy was uninvestigated in fecal incontinence.
Great, Amol. That just as you were talking, I thought of something which is probably relevant or more out of curiosity. So you said this is for fecal incontinence. Does it distinguish between fecal incontinence, which is truly due to sphincter dysfunction, versus fecal incontinence, which can occur in patients with overflow diarrhea?
So, oftentimes you just highlighted a very important point. Patients with fecal incontinence also have coexisting constipation. And in our study, and I think most fecal incontinence studies, they don't screen out patients with constipation. So in terms of, does it help patients with overflow diarrhea? Well, it just depends on their sphincter profile. And if it is conducive to more incontinence, then it would be just as effective. The other thing is that oftentimes people with coexisting constipation and fecal incontinence, they're hesitant to really aggressively treat their constipation for worsening their incontinence. So their constipation remains untreated.
Great. So in general, what was the aim of the clinical trial, or what were your primary outcomes or hypotheses behind the study?
Sure. So our hypothesis was that home biofeedback therapy using this novel device is non-inferior to traditional biofeedback therapy in the office in treating fecal incontinence. Our aim was to compare the short-term efficacy, feasibility, safety of home biofeedback with office biofeedback in a prospective randomized control trial.
Great. And can you briefly describe the study design or the trial design for this study?
Sure. So it was a randomized control trial, non-inferiority trial. Pre-screening included history and physical, as well as an anorectal manometry. And then during screening, potential study subjects maintained a 2-week stool diary and completed validated fecal incontinence symptom severity and quality of life questionnaires. Subjects with fecal incontinence were then randomized 2-to-1 to home versus office biofeedback arms, respectively. And then they underwent treatment for 6 weeks while maintaining a stool diary. At the end of the study, we repeated validated questionnaires and anorectal manometry, and our target for the study was about 30 subjects. Our primary outcome was responder rate, and a responder was defined by a greater than or equal to 50% decrease in weekly FI episodes or fecal incontinence episodes. Other outcomes that we looked at was stool frequency, consistency, use of pads every week, validated measures of fecal incontinence severity, quality of life, and anorectal manometry parameters.
Great. And what were your key findings?
So before we get there, I just want to describe this home biofeedback therapy device in a little bit more detail so our listeners have a better appreciation for it. The device is quite interesting. It's an inflatable probe that allows for subjects to have sphincter resistance training, but on the sides of the inflatable probe, there are metal electrodes that provide low frequency electrical stimulation, which is different than what we use for office biofeedback. There's a handheld monitor that has a timer on it, and then we've provided the patient with tailored voice-guided instructions. And for the patient on the device itself, there's also a visual LED lighted feedback, biofeedback. Actually, that's part of the biofeedback. It's a lighted feedback that helps them gear their strengthening exercises based on that response. So the program that we developed for biofeedback on the home device includes 6 short 5-second squeezes, 6 25-second long squeezes, and then a 2-minute period of low amplitude electrical stimulation, and then 1 5-minute long period of electrical stimulation. So as you can see, there's both electrical stimulation and muscle resistance training involved with home biofeedback, which is different than our in-office traditional biofeedback. The level of electrical stimulation was set at a level that induces anal sphincter contractions, but doesn't cause discomfort to the patient. So they were instructed during the study to use this device for twice a day for 6 days a week. And then their compliance with the device could actually be recorded and captured. The home office biofeedback, which we traditionally do in our clinical practice, was the same. It's also the same as what was performed in our landmark randomized control trial that was led by my colleague, Dr. Satish Rao, that proved that in-office biofeedback was superior to sham and standard medical therapy for the treatment of fecal incontinence. And that people had to come every week, once a week in the office for 1 hour long sessions. So moving to the key findings in the study. So we screened about 85 patients with fecal incontinence and enrolled 33. 3 of the patients in the home arm, we had a drop because of 2 were discovered to have a rectal prolapse, and 1 was an undisclosed cardiac pacemaker. So we had 20 in the home arm and 10 in the office arm. And then the primary outcome was about a 65% responder rate in the home biofeedback arm, and then a 60% responder rate in the office biofeedback arm, which was not statistically significantly different. And that was the purpose of the non-inferiority trial. There was really no difference in the weekly FI episodes between the 2 groups, and no difference really in the stool frequency or stool consistency between the 2 groups. All the symptom severity and quality of life validated measures improved in the home arm, not so much in the office arm, but there was no real difference between the 2 groups. In terms of anorectal manometry parameters and rectal sensory parameters, all the anal sphincter profiles of resting anal sphincter pressure, max squeeze pressure, and sustained squeeze pressure improved in both groups. That was significant, but really no improvements in any of the rectal sensation and rectal sensory thresholds in the groups. In terms of adverse events, there was no serious adverse event observed. In the office arm, 1 subject had some mild rectal tenderness and 2 subjects had some self-limited bleeding. There were minor adverse events in the home arm, including 4 non-device related adverse events. And 2 patients had a little bit of discomfort with the device. 1, we had to down adjust the stimulation intensity and they were able to complete the study. And 1 had some self-limited rectal bleeding, likely from some hemorrhoids, and also was able to complete the study.
Great. I mean, as you were telling me, how do you ensure compliance in the home program, or how do you know whether the patients have been doing what they're doing? Is that what they're saying?
Yeah, so in the device itself, it had a neat feature that allowed us to capture how often the device was turned on and used. So, in real clinical practice, and probably in a more advanced version of the device, that could probably link up to a Bluetooth or Wi-Fi and allow a managing provider to see how often it's being used. So I think that would be a helpful measure to make sure that the patient is working hard, because this does require a lot of patient participation and buy-in to really have success.
Yeah, I know that's it'll be interesting to see the profile of patients who respond and don't respond, and their level of motivation. But obviously this was a really important study, or the first step to try and move towards home programs. So what do you think the impact of the study is? Does this open door for additional studies, or do you think this is sufficient to warrant recommending home biofeedback for patients?
Yeah, so I mean, obviously this was a small study, 30 subjects, and I hope that this paper will generate enough interest, like you mentioned, and lead to a larger multi-center sham-controlled randomized trial to further establish its efficacy and safety. But also I hope that this study piques some interest in researchers that are interested in finding a solution for these patients that are suffering from this widely prevalent and terrible condition, and kind of appreciate the multifaceted neuromuscular problem that fecal incontinence is, both a disorder of muscle and nerves in the pelvis. And in developing therapies, recognition of addressing both may be helpful.
So beyond the larger study participation. Is there anything else that you would like to see in the next iteration of a clinical trial looking at this?
Yeah, so, I think we've proven that this will have safety and feasibility in this study. Efficacy we touched on, but then also from a patient perspective, hopefully we have further improvement in cost expenditure for these patients whose bills rise again, maybe improvement in other outcomes that we mentioned, maybe a decrease in nursing home placement for these patients. Maybe they're able to maintain their independence and decrease reliance on other people. So, fecal incontinence being the second most leading cause of nursing home referral with these patients, if they're able to maintain their independence, and this isn't a limitation to their other health conditions, hopefully, given that we have a very fastly and rapidly progressing aging population, I think that the prevalence is just going to increase and the healthcare burden is also going to increase. So hopefully we have downstream effects on healthcare expenditure, cost, patient satisfaction, patient morbidity.
That's great. I think that's sort of what I was getting from initial conversations. This has not only impacts on patient outcomes and patient satisfaction, but it has more broad societal and economic implications also. Any other final thoughts about the study or the future of research in this area, and what's on your pipeline or list of things to do next after this?
Yeah, so we're just not hanging our hat on home biofeedback therapy. We have 2 NIH trials looking at magnetic neuromodulation in the lumbosacral region as a treatment for fecal incontinence. Also, we're involved in a multi-center NIDDK study looking at various available treatments and comparing their efficacy, finding moderators of disease in those patients. So I think your listeners should leave this podcast with hope that treatment strategies are being evolved for these patients, apart from the ones that are currently existing. And hopefully we're able to find the most efficacious and patient-specific treatment for patients with fecal incontinence that they can all benefit from.
Great, and thank you for this work. So I'd like to thank you again, Amol, for the excellent paper and also for joining us to discuss the paper for this podcast. And I'd also like to thank our audience for tuning in to listen to this podcast, and I look forward to welcoming you again next month with another exciting article.
Thank you, Purna.